urinalysis. This is a chapter from your urinalysis and body fluids textbook, and we are going to discuss everything about analysis of the feces, which is sometimes done in the urinalysis laboratory. Here are your objectives. When you have time, please do these on your own or just go through them on your own. And okay, so let's start with a quick introduction. And what is feces? Feces are the end product of digestion. We in the laboratory can do an analysis of the feces macroscopically, microscopically, or we can do a chemical analysis. And doing these types of analysis helps in to detect different conditions. It helps us detect the conditions in the gastrointestinal tract, like gastrointestinal bleeding, conditions of the liver and the biliary duct, conditions of maldigestion and malabsorption, pancreatic diseases, inflammation, diarrhea and statorrhea, and detection and identification of pathogenic bacteria, viruses, and parasites. So now let's talk about the physiology of the feces. The fecal specimen obviously has bacteria, cellulose, undigested food, GI secretions, gastrointestinal secretions, bile pigments, and cells from the intestinal walls. Also, it has some electrolytes and water. About 100 to 200 grams of feces is excreted in a 24-hour period for a normal adult. The small intestine is the primary site for the final breakdown and reabsorption of proteins, carbohydrates, and fats. This process is aided by pancreatic enzymes and bile salts. Under normal conditions, only between 500 to 1500 mL of fluid reaches the large intestine, and only about 150 mL is excreted in the feces. Approximately 9,000 mL of ingested fluid, saliva, gastric, liver, pancreatic, and intestinal secretions enter the digestive tract each day. The majority of these fluids involved in digestion are reabsorbed, with only about 150 mL that is excreted in the feces. When there is excess water or water over 3,000 mL that reaches the large intestine, that will result in diarrhea. Here in this picture, what you can see is the fluid regulation in the gastrointestinal tract. Approximately 9,000 milliliters of ingested fluid, saliva, gastric, liver, pancreatic, and intestinal secretions enter the digestive tract each day. Again, under normal conditions, only about 500 to 1500 mL of this fluid reaches the large intestine, and only about 150 mL is excreted in the feces. Water and electrolytes are readily absorbed in both the small and large intestines, resulting in a fecal electrolyte content that is similar to that of the plasma. Okay, so now let's talk about the clinical classification of diarrhea. Diarrhea classification can be based on 4 different factors: the illness duration, the mechanism, the severity, and the characteristics of the stool. Diarrhea that lasts less than 4 weeks is defined as acute diarrhea, and diarrhea that persists for more than 4 weeks is termed chronic diarrhea. So diarrhea is anything that's over 200 grams of stool weight per day, with increased liquid and more than 3 bowel movements per day. The major mechanisms that cause diarrhea are secretory, osmotic, and intestinal hypermotility. Watery diarrhea is divided into secretory or osmotic types by measuring fecal electrolytes and the osmotic gap. The laboratory tests used to differentiate these mechanisms include fecal electrolytes, which is fecal sodium or fecal potassium. We can also test for fecal osmolality, and we can also test for the fecal pH or the stool pH. One thing to notice is that the normal total fecal osmolarity is close to the serum osmolality of 290 milliosmoles per kilograms. The normal fecal sodium is 30 millimoles per liter, and the normal fecal potassium should be about 75 millimoles per liter. We use the fecal sodium and the fecal potassium to calculate the fecal osmotic gap. And here is a slide that shows you the fecal osmotic gap. Again, the fecal osmolarity is close to the serum osmolarity, which should be about 290 milliosmoles per kilograms. The osmotic gap is measured as you can see here in the formula. 290 times 2 times the fecal sodium plus the fecal potassium. The stool osmotic gap is a measurement of the difference in the solute between the serum and the feces. And again, it's used to distinguish among different causes of diarrhea. The feces is normally in osmotic equilibrium with the blood serum. The human blood serum should have an osmolarity level of about 290 to 300 milliosmoles per kilogram. Again, as I said earlier, the fecal sodium and the fecal potassium results are used to calculate the fecal osmotic gap using the formula that is shown here in this particular slide. Secretory diarrhea is caused by increased secretion of water. Bacterial, viral, and protozoan infections produce increased secretion of water and electrolytes, which override the reabsorptive ability of the large intestine. This will lead to secretory diarrhea. Enterotoxin-producing organisms such as Escherichia coli, Clostridium, Vibrio cholerae, Salmonella, Shigella, Staphylococcus, Campylobacter, different types of protozoa and parasites such as Cryptosporidium can all stimulate the secretions of water and electrolytes. Other causes of secretory diarrhea can be drugs, stimulant laxatives, hormones, inflammatory bowel disease like Crohn's disease, ulcerative colitis, lymphocytic colitis, diverticulitis, endocrine disorders such as hyperthyroidism, neoplasms, and collagen vascular diseases. Osmotic diarrhea, on the other hand, is caused by poor absorption that exerts osmotic pressure across the intestinal mucosa. Incomplete breakdown or the reabsorption of food presents increased fecal material to the large intestine, resulting in retention of water and electrolytes in the large intestine. This is why it is called osmotic diarrhea. This in turn results in a stool that is excessively watery. Again, asthmatic diarrhea is caused by poor absorption that exerts osmotic pressure across the intestinal mucosa. Maldigestion, which is impaired food digestion, and malabsorption, which is impaired nutrient absorption by the intestine, both contribute to asthmatic diarrhea. The presence of unabsorbable solute increases the stool osmolality, and the concentration of electrolytes is lower, resulting in an increased osmotic gap. Other causes of asthmatic diarrhea can include disaccharide deficiency, otherwise known as lactose intolerance, malabsorption, which is a celiac sprue, poorly absorbed sugars like lactose, sorbitol, or mannitol, laxatives, magnesium-containing antacids, amoebiasis, antibiotic administration could be another cause of asthmatic diarrhea. Lab testing of the feces is performed frequently to aid in determining the cause of diarrhea. Altered motility. Altered motility describes the conditions of enhanced motility or hypermotility or slow motility, which is otherwise known as constipation. Hypermotility is enhanced motility, and slow motility is constipation. Altered motility describes conditions of either enhanced motility, right? Enhanced motility when a person is constantly using the bathroom and having some bowel movements. And both of these can be seen in patients with irritable bowel syndrome, IBS, which is a functional disorder in which the nerves and the muscles of the bowel are extra sensitive, causing cramping, bloating, flatus, diarrhea, and constipation. IBS can be triggered by food, chemicals, emotional stress, and also exercise. In this particular slide, you see the differential features for diarrhea. What are the differences between asthmatic diarrhea and secretory diarrhea? So for asthmatic diarrhea, the osmotic gap would be over 75 osmoles per kilograms, and in secretory diarrhea, the osmotic gap is usually less than 50. The stool sodium in asthmatic is less than 60 millimoles per liter, and in secretory is over 90 millimoles per liter. The stool output in 24 hours is less than 200 grams in osmotic diarrhea and over 200 in secretory diarrhea. The pH in osmotic diarrhea is less than 5.3 and over 5.6 in secretory diarrhea. Reducing substances, which is another test that we perform in the laboratory, is positive for osmotic and negative for secretory diarrhea. Now we move on to statorrhea. Statorrhea, the detection of this kind of statorrhea, or otherwise known as what is increased fats in the stool over 6 grams per day. Detection of statorrhea or fecal fat is very useful in diagnosing pancreatic insufficiency and small bowel disorders that cause malabsorption. Absence of biosalts that assist pancreatic lipase in the breakdown and subsequent reabsorption of dietary fat, primarily triglycerides, produces an increase in stool fat, otherwise known as statorrhea. This exceeds usually over 6 grams per day. Likewise, pancreatic disorders, including cystic fibrosis, chronic pancreatitis, carcinoma, that decrease the production of pancreatic enzymes, are also associated with steatorrhea. Steatorrhea may be present in those with either maldigestion or malabsorption conditions and can be distinguished by using the D-xylose test. D-xylose, as you may recall, is a sugar that does not need to be digested, but does need to be absorbed to be present in the urine. If the urine D-xylose is low, the resulting steatorrhea indicates a malabsorption condition. Malabsorption causes may include bacterial overgrowth, intestinal resection, celiac disease, tropical sprue, lymphoma, Whipple disease, Giardia lamblia infestation, Crohn's disease, and intestinal ischemia. A normal D-xylose test indicates pancreatitis. Okay, so now let's talk about specimen collection for fecal analysis. Collection of a fecal specimen is typically called a stool specimen. It's not an easy task for the patients. Usually, detailed instructions in appropriate containers, depending on the type of test and the amount of feces that is required, should be provided to the patient. For certain tests, dietary restrictions are required before a fecal specimen is collected. Patients should be carefully instructed to collect the specimen in a clean container, such a bedpan or a disposable container, and transfer the specimen to the laboratory container. Patients should understand that the specimen must not be contaminated with urine or toilet water, which may contain chemical disinfectants or deodorizers that can interfere with chemical testing. Containers that have preservatives for ova and parasites must not be used to collect regular stool specimens. They should only be used to collect ova and parasite specimens. Random specimens are suitable for qualitative testing for blood and microscopic examination for leukocytes, muscle fibers, and fecal fats. And these are usually collected in plastic or glass containers with screw tops similar to those that we use for urine specimens. For quantitative testing, such as quantitative testing for fecal fats, timed specimens are required. Because of the variability of bowel habits and the transit time required for food to pass through the digestive tract, the most representative specimen is a 3-day collection specimen. Frequently, these specimens are collected in large containers to accommodate the specimen quantity and facilitate emulsification before testing. This has to be reminded to the patients that care must be taken when opening any fecal specimen to release gas that has accumulated within the container slowly. Patients must be cautioned not to contaminate the outside of the container as well. So, collecting a sample for feces analysis is a process, and it is very important that the patients know and they are instructed on how to do it. And it is also very important that the medical lab scientist knows how to process the specimen when they are ready to process the specimen for whatever test that may be. Okay, so we do 3 types of testing of the feces in the lab: macroscopic, microscopic, and chemical testing. The macroscopic screening is a way that we define or we find kind of whether or not we can see that a disorder might be happening with a patient. Often the first indication of gastrointestinal disturbances can be changes in the brown color and form consistency of the normal stool. So, the color and the appearance or the formation of it is examined macroscopically. Okay, so macroscopically, we are looking at the color and consistency of the stool. So let's talk about the color. Typically, the color of the stool is brown. The brown color of the feces results from the intestinal oxidation of stercobilinogen to urobilin. So that's where the brown color comes from. Remember that conjugated bilirubin formed in the degradation of hemoglobin passes through the bile duct to the small intestine, where in that particular place in the small intestine, intestinal bacteria converted to urobilinogen and stercobilinogen. Therefore, the stool appears pale in instances where there is a slight blockage of the bile duct. Pale stools are usually associated, or they are associated with diagnostic procedures that use barium sulfate. So a primary concern in the stool when you're looking at the color is the presence of blood in the sample. So depending on the area of the intestinal tract from which bleeding occurs, the color of the stool can range from bright red to dark red or black. Blood that originates from the esophagus, the stomach, or the duodenum takes approximately 3 days to appear in the stool. During this time, degradation of hemoglobin produces the characteristic black tarry stool. Blood that comes from the lower GI tract requires less time to appear, and it retains that bright red color. Both black and red stools should be tested chemically for the presence of blood, because ingestion of iron, charcoal, or bismuth often produces black stool, and in some medications and also some foods, including beets, produce a red colored stool. Green stools may be observed in patients that are taking oral antibiotics because of the oxidation of fecal bilirubin to biliverdin. Ingestion of increased amounts of green vegetables or food coloring also produces green stool. Okay, so now let's talk about the appearance. Besides variations in color, additional abnormalities may be observed during macroscopic examination. And those include the consistency, of the stool. So, if there is a watery consistency of the stool, right, that may mean that the patient has diarrhea. Small, hard stools are usually seen with constipation. Slender or ribbon-like stools usually suggest some sort of obstruction of the normal passage of material through the intestine. Again, pale stools are associated with biliary obstruction and steatorrhea. Sometimes they appear bulky and frothy, and they have a foul odor. The presence of mucus-coated stools indicates intestinal inflammation or irritation. Mucus-coated stools may be caused by pathological colitis, Crohn's disease, colon tumors, or excessive straining during elimination. Blood-streaked stools or blood-streaked mucus suggest damage to the intestinal walls, possibly caused by bacterial or amoebic dysentery or malignancy. The presence of mucus is abnormal and it should be reported. Okay, so now let's move on to the microscopic examination of the fecal matter. So one of the first things that we are going to do is inspect microscopically. Once you move on from analyzing the stool macroscopically, you're going to move on to do the microscopic testing. One of the tests that we do in the lab for the microscopic portion of it is the fecal leukocytes. We're actually looking for neutrophils, okay? These are a type of white blood cells. So the microscopic part of this is very helpful in detecting the presence of leukocytes because these can be associated with microbial diarrhea. We also look for undigested fibers and fats that are associated with diarrhea. Leukocytes are seen in the feces in patients with conditions that affect the intestinal mucosa, such as ulcerative colitis and bacterial dysentery. The microscopic review or the microscopic screening of the fecal matter is performed as a preliminary test to determine whether diarrhea is being caused by an invasive bacterial pathogen, and that could include Salmonella, Shigella, Campylobacter, Yersinia, or an enteroinvasive E. coli. These are bacteria that can cause diarrhea by toxin production, such as Staph aureus or Vibrio species. We are also looking for leukocytes to find out if the patient has some sort of virus and parasites. But typically, we're more concerned with the formation of leukocytes due to bacterial pathogens, not so much with the viruses and parasites. So the presence or absence of fecal neutrophils can provide the physician or the caring nurse or physician assistant with diagnostic information before receiving a culture report from the fecal matter. Okay. So what do we do here when we are looking for neutrophils, for fecal leukocytes? Specimens can be examined as a wet preparation that's stained with new methylene blue, or as dried smears that are stained with Wright's or Graham stain. The new methylene blue stain is a faster procedure, but maybe a little bit more difficult to interpret. Dry preparations stained with either Wright's stain or Graham stain provide a permanent slide for evaluation. Also, if you do a Gram stain, that gives you an additional advantage in which you will be able to see Gram positive or Gram negative bacteria, which could help in the initial treatment for the patients. Keep in mind that all slide preparations have to be done on a fresh specimen. In an examination of preparations under high power, as few as 3 neutrophils per high power can be indicative of an invasive condition. When you use oil immersion, the finding of any neutrophils has approximately 70% sensitivity for the presence of an invasive bacteria. We can also do a lactoferrin latex agglutination test. A lactoferrin latex agglutination test is available for detecting fecal leukocytes and remains sensitive in refrigerated and frozen specimens. The presence of lactoferrin, which is a component of a granulocyte secondary granule, indicates an invasive bacterial pathogen. Here is a procedure for analyzing bacterial or fecal leukocytes using the methylene blue stain. First, you will place mucus or a drop of liquid stool on a slide. Then you will add 2 drops of loafer new methylene blue. You will mix that with a wooden applicator stick. You will allow this sample to stand for 2 to 3 minutes, and then you will examine for neutrophils under high power. Microscopically, we also look for the muscle fibers. The microscopic examination of the feces for undigested striated muscle fibers can be helpful in diagnosing and monitoring patients with pancreatic insufficiency. Some people have pancreatic insufficiencies when they have cystic fibrosis, for example. This test, this muscle fiber test, is frequently ordered next to or with a microscopic examination for fecal fats. Increased amounts of striated fibers also may be seen in patients with biliary obstruction, malabsorption syndromes, and gastrocolic fistulas. Slides for the detection of muscle fibers I prepared by emulsifying a small amount of stool in 10% alcoholic eosin. This enhances the muscle fiber striations. The entire slide is examined for exactly 5 minutes, and the number of red stained fibers with well-preserved striations is counted. Care must be taken to classify the fibers observed correctly. Undigested fibers have visible striations running both vertically and horizontally. Partially digested fibers exhibit striations in only one direction, and digested fibers have no visible striations. Only undigested fibers are counted, and the presence of more than 10 is reported as an increase. To produce a representative specimen here, patients should be instructed to include red meat in their diet before collecting the specimens. Specimens should be examined within 24 hours of collection. And here is an example of muscle fibers that are detected microscopically. And to go back to what I said in the previous slide, you have to examine the entire slide for 5 minutes, and you will count the number of red strained fibers with well-preserved striations. Undigested fibers have visible striations running both vertically and horizontally. Only undigested fibers are counted, and the presence of more than 10 is reported as an increase. Okay. Now let's talk about qualitative fecal fats. So specimens that are suspected to have, or patients that are suspected to have steatorrhea can be screened microscopically for the presence of excess fat. Okay, remember, excess fat in the stool is called steatorrhea. Also, the procedure can be used to monitor patients undergoing treatment for malabsorption disorders. The lipids that is included in the microscopic examination of the feces are neutral fats such as triglycerides, fatty acid salts, fatty acids, and cholesterol. Their presence can be observed microscopically by staining with the dye Sudan 3, Sudan 4, or oil red O. Sudan 3 is the one stain that is used more commonly. The staining procedure consists of 2 different parts: the neutral fat stain and then the split fat stain. This is the 2-part test: neutral fat and the split fat test. Neutral fats are readily stained by Sudan 3 and appear as large orange to red droplets. They are often located near the edge of the cover slip. We have to observe the slide for more than 60 droplets under high power. And if we do, that indicates the presence of steatorrhea. However, when we do the split fat stain, that represents the total fat content, and that can provide a better indication of steatorrhea. Breakdown of neutral fats by bacterial lipase and spontaneous hydrolysis of neutral fats may lower the neutral fat content, which precludes comparison of the two slide tests to determine whether there is maldigestion or malabsorption that's causing the steatorrhea. So, split fat test is definitely more indicative here. Here is the procedure for the neutral fat stain. You homogenize 1 part stew with 2 parts water. You mix the emulsified stew with 1 drop of 95% ethyl alcohol on the slide. You add 2 drops of saturated Sudan 3 in 95% ethanol. You mix and apply the cover slip. You will then examine the slide under high power. As you examine, you will count the orange droplets per high power field. Here is the split fat stain procedure. You will mix the specimen with acetic acid and heat the sample. Free fatty acids and fatty acids from soap, hydrolysis, and neutral fats will be determined using the split fat stain. You will count and you will actually count the number of fat droplets and evaluate the size. A sample is normal when there is up to 100 small fat droplets per high power field. It is slightly increased when there is 100 and the size is about 128 micrograms. And the sample is increased of fat when there is 100, but the size of the droplets are bigger. They're about 6 to 75 micrometers in size. You may also see some cholesterol crystals that form after the heating and the cooling while you do the procedure. These will have a characteristic flat shape and notched corners. Again, these are cholesterol crystals that you may come across while you do your split fat stain procedure. So again, here is the procedure. You mix emulsified stew fat with 1 drop of 36% acetic acid. You will add 2 drops of saturated Sudan 3. You will mix and apply a cover slip. You will heat gently, almost to a boiling point. Then you will examine under high power, count and measure the orange droplets per high power field. Another test that we do very frequently in the laboratory as we are examining the stool is called the occult blood test. This is by far the most frequently performed fecal test, which helps us identify occult blood or hidden blood. Remember that bleeding in the upper gastrointestinal tract may produce a black tarry stool, and bleeding in the lower gastrointestinal tract may result in an overtly bloody stool. However, because any type of bleeding in excess of 2.5 milliliters per 150 grams of stool is considered pathologically significant, no visibles and basically no visible sign of bleeding may be present with this amount of blood, fecal occult blood testing is absolutely necessary. Fecal occult blood testing, FOBT. So again, this is a very, very common test that we do in the lab. It helps us determine the occult blood or the hidden blood. Again, the black tarry stool can come from upper gastrointestinal tract bleeding. However, if there is bleeding in the lower gastrointestinal tract, you'll see more of a red appearance. But because any amount of blood in the stool is significant and it may not be visible, it is important to do a test that will detect the blood even if we can't see it. So this is exactly what occult blood does. Annual testing for occult blood has a high positive predictive value for detecting colorectal cancer in the early stages, and it is recommended by the American Cancer Society, particularly for people over 50 years of age. This test may also be performed to evaluate possible causes of unexplained anemia. So there are different methods. The common method for detecting occult blood includes the guaiac method, but there are also some immunochemical or fluorometric porphyrin quantification tests. The immunochemical tests and fecal porphyrin quantification tests are more sensitive and more specific than the guaiac-based fetal occult test. Here is the principle of the guaiac-based fecal occult blood test. The screening test, the screening test for the fetal occult blood uses guaiac-based test, and it is really based on the fact that it can detect the pseudoperoxidase activity of hemoglobin. This is the same principle as the reagent strip test that we use for urinary blood, but it uses a different indicator chromogen here. The reaction uses the seroperoxidase activity of hemoglobin reacting with hydrogen peroxide to oxidize a colorless compound to a colored compound. Please see the video that I have posted in the course about this particular test principle using the pseudoperoxidase activity of hemoglobin. This is the occult blood guaiac test. You should be able to see that in your course. Again, the guaiac principle is less sensitive than the urinalysis reagent because up to 2.5 mL of blood in the stool can be normal. This can help eliminate false positives from vegetable and bacterial peroxidases and diet as well. Many commercial testing kits are available for occult blood testing with the guaiac reagent. The kits typically contain guaiac impregnated filter paper enclosed in a cardboard slide to which the fecal specimen and hydrogen peroxide are added. 2 or 3 filter paper areas are provided for the application of material taken from different areas of the stool and for the positive and negative controls that must be included. When you obtain a sample from the center of the stool, that helps avoid false positive reactions from external contamination. The patient, right before we do this test, is asked to collect samples from stool specimens collected on 3 consecutive days. The sample is placed on the front side of the slide with an applicator stick, and the slide is closed. Adding hydrogen peroxide to the back of the filter slide that contains the stool produces a blue color with guaiac reagent when pseudoperoxidase activity is present. And here are some false positive and some negative reactions that may occur that you need to be aware of. You may get a false positive in the presence of aspirin and anti-inflammatory medications, red meat, horseradish, raw broccoli, cauliflower, radishes, turnips, melons, and menstrual or hemorrhoid contamination. False negatives, on the other hand, can come from high levels of vitamin C and iron supplements that contain vitamin C. Here's an example of a figure that is shown in your book showing you the fecal occult blood reaction. As you can see in the A picture, it shows you a negative result for occult blood indicated by the absence of the blue color. In slide B on the right, you'll see a positive result for occult blood indicated by the blue color around the edge of the stool sample. Note the control area inside the orange rectangle. The positive control appears blue and the negative control shows no color. It is very important to run the controls that are within your test cartridge. Okay, so there are more sensitive occult blood tests. The immunochemical fecal occult blood test, IFOBT, is specific for the globin portion of the human hemoglobin and uses polyclonal anti-human hemoglobin antibodies. Because this method is specific for human blood in feces, it does not require dietary or drug restrictions. It is definitely more sensitive to the lower GI bleeding, and that can be an indicator of colon cancer or other gastrointestinal disease, and can be used for patients who are taking aspirin and other anti-inflammatory medications. The immunochemical fecal occult blood test does not detect bleeding from other sources, such as a bleeding ulcer. Okay, hemoglobin from the upper GI tract bleeding is degraded by bacterial and digestive enzymes before reaching the large intestine, and it is immunochemically non-reactive. In contrast, there is little hemoglobin degradation in the lower GI bleeding, when there is lower GI bleeding, so the blood is immunochemically active. The collection kits for the immunochemical fecal occult blood test are similar to those that we use for the guaiac testing, and they could be sold by Beckman Coulter or Fullerton, and these are called hemo-occult ICT tests. They can also be provided to the patients for home collection. Okay. Quantitative fecal fat analysis is used as a confirmatory test for steatorrhea. As discussed earlier, quantitative fecal analysis requires a collection of at least a 3-day specimen. The patient must maintain a regulated, intake of fat, about 50 to 100 grams each day, for 2 to 3 days before and during the stool collection period. The specimen has to be collected in a large pre-weighed container. Before the analysis, the specimen is weighed and homogenized. Refrigerating the specimen prevents any bacterial degradation. The method used routinely for fecal fat measurement is the Kramer titration, although the gravimetric near infrared reflected spectrometry, the NIRS, and the nuclear magnetic resonance spectroscopy methods are also available. In the titration method, fecal lipids are converted to fatty acids and titrated to a neutral endpoint with sodium hydroxide. Approximately 80% of the total content is measured by titration, whereas in the gravimetric method, it measures all of the fecal fat. A drawback of the titration of the gravimetric methods is that it is time-consuming and uses solvents that could be corrosive and flammable. A rapid and safe procedure for analyzing quantitative fecal fat is the hydrogen nuclear magnetic resonance spectroscopy, the HNMR method. In this method, the homogenized specimen is microwaved, dried, and analyzed. The results correlate well with the gravimetric method, and it is widely used in reference laboratories. When you are doing a quantitative fecal fat test, the fat content is reported as grams of fat or the coefficient of fat retention per 24 hours. Reference values based on 100 grams per day intake are 1 to 6 grams per day, or a coefficient of fat retention of at least 95%. The coefficient of fat retention is calculated as you can see here. The dietary fat minus the fecal fat over the dietary fat times 100. Although the Van de Kamer titration is the gold standard for fecal fats, the acid statocrit is a rapid test to estimate the amount of fat excretion. It is similar to the microhematocrit test, and it is more convenient than the 72-hour stool collection. The acid statocrit test is a reliable tool to monitor a patient's response to therapy and to screen for steatorrhea in pediatric populations. The hydrogen nuclear magnetic resonance spectroscopy, the HNMR test, again, is the rapid 5-minute test. It is a safe procedure for analyzing quantitative fecal fat. The sample here is microwaved, dried, and analyzed. It is a very quick procedure, it's less invasive, and it takes about 5 minutes to perform. The acid statocrit test provides the rapid estimate of fat content. You need a single specimen, and it can help monitor the response to therapy and also to screen the pediatric population, as mentioned earlier. 5 grams of specimen is homogenized and acidified. The homogenized specimen is spun in a regular hematocrit tube. You measure the length of the fatty top layer and the length of the solid bottom layer. Here are the calculations or the formulas that you may use to calculate the acid statocrit. As you can see right on the first layer, the first table in here, this is the formula that we use to calculate the acid statocrit as a percentage. You take the acid statocrit as you take the fatty layer in length in centimeters, divided by the fatty layer in length, in centimeters, plus the solid layer length times 100. The fecal fat for adults is quantified as follows, right in the second table right here. 0.45 times the acid statocrit in percent as a whole number minus 0.43. An acid statocrit value of less than 31% it's considered normal, whereas a value of over 31% indicates steatorrhea in adults. The fecal fat for children up to the age of 15 can be calculated as follows. 0.1939 times the acid statocrit in percent as a whole number minus 0.2174. The acid statocrit is typically higher in infants and lowers with the age. For infants older than 6 months of age, a value of less than 10% is normal, 10% to 20% is equivocal, and a value over 20% is abnormal, indicating steatorrhea. Infants younger than 6 months of age show a high and widely variable statocrit value. NIRS stands for the Near Infrared Reflectance Spectrophotometry, NIRS. This is a rapid procedure for fecal fat that requires less stool handling by the professional laboratory personnel. The test requires a 48 to 72 hour collection of the stool to exclude a day-to-day variability, but it does not require reagents after homogenization of the sample. The results are based on the measurement and computer processing of signal data from reflectance of the fecal surface, which is scanned with infrared light between 1400 to 2600 nanometers wavelength. The results are calculated from calibration derived from the known samples. The technique quantitates water, fat, and nitrogen in grams per 24 hours. And a summary of the test and current instrumentation for fecal fat analysis is presented in your textbook. We also do something called the APT test for fetal hemoglobin. Grossly bloody stools and vomit are seen sometimes in neonates as the result of swallowing maternal blood during delivery. Sometimes it is necessary to distinguish between the presence of fetal blood or maternal blood in an infant stool or vomit, and we use the APT test to do this. The material to be tested is emulsified in water to release the hemoglobin, and after centrifuging the sample, 1% of sodium hydroxide is added to the pink hemoglobin containing supernatant. In the presence of an alkali-resistant fetal hemoglobin, the solution remains pink. That's when there is hemoglobin F. Whereas denaturation of the maternal hemoglobin, which is hemoglobin A, produces a yellow to brown supernatant after standing for 2 minutes. The APT test distinguishes between not only hemoglobin A and hemoglobin F, but also between maternal hemoglobins AS, CS, and SS, and hemoglobin F. The presence of maternal thalassemia major would actually produce erroneous results due to the high concentration of hemoglobin F in the sample. Stool specimens that are tested using the APT test should be fresh. They may appear bloody, but should not be black and tarry, because this could indicate an already denatured hemoglobin in the sample. And again, here is the procedure for the APT test, which is taking the material that is emulsified in water to release the hemoglobin. Then you centrifuge the sample. 1% of sodium hydroxide is added to the pink hemoglobin containing supernatant. In the presence of these alkali-resistant fetal hemoglobin, the solution will remain pink, whereas denaturation of the maternal hemoglobin, which is hemoglobin A, this will produce a yellow to brown supernatant after it stands for 2 minutes. Again, this test will help us distinguish between hemoglobin A or hemoglobin S, the presence of maternal hemoglobin or fetal hemoglobin. We need to use controls when we are using this APT test. We can also test for fecal enzymes. Pancreatic enzymes are associated with pancreatic insufficiencies and a disease called cystic fibrosis. These are some examples of the enzymes: trypsin, chymotrypsin, elastase 1. We can do the classic trypsin test, which the stool dissolves gelatin on an X-ray paper, but this is not a very sensitive test. The chymotrypsin test is more sensitive. It is less degraded than trypsin, and spectrophotometric measuring is available for this particular enzyme. Elastase 1 is another very important pancreatic enzyme. It is an isoenzyme of elastase produced by the pancreas. It is present in high concentrations and is resistant to degradation. It is a very pancreas-specific enzyme, and it is not affected by gastric motility and other mucosal defects. There are immunoassay kits that can test for elastase 1. It only requires a single specimen and uses monoclonal antibodies for human elastase 1. It helps differentiate pancreatic from non-pancreatic causes of steatorrhea. Also, when we analyze fecal matter, we can test for carbohydrates. Remember, the enzymes supplied to the gastrointestinal tract by the pancreas are essential for digesting dietary proteins, carbohydrates, and fats. Decreased production of these enzymes, where there is pancreatic insufficiency, is associated with disorders such as chronic pancreatitis and cystic fibrosis. When steatorrhea occurs, undigested food can appear in the feces. Increased stool carbohydrates cause osmotic diarrhea because of excess water is needed to remove the carbohydrates. Also, there is the inability to reabsorb or the lack of digestive enzymes that cause the issue. Typically, there is an idiopathic lactase deficiency that can lead to the presence of carbohydrates. If there is suspicion of maldigestion, you can do the lactose tolerance test. And if there's suspicion of malabsorption disorders, you can do the D-xylose test. There's also some common fecal testing on infants. The pH is performed to detect, the pH of the sample is performed to detect fermentation of excess carbohydrates by intestinal bacteria. The normal stool pH should be between 7 to 8, and a pH below 5.5 indicates increased carbohydrates. Remember that the Clini test is a 1 part stool and 2 parts water. You emulsify and perform a routine test. Anything over 0.5 grams per deciliter is abnormal. The test distinguishes between carbohydrate caused and bacterial or viral caused diarrhea. You can follow a positive Clini test with the tolerance test. Remember that sucrose is not detected by the Clini test method because it is not a reducing sugar. In premature infants, there is a correlation between a positive Clini test and an inflammatory necrotizing enterocolitis. As discussed previously, this is the general test for the presence of reducing substances, and a positive test result would be followed by more specific serum carbohydrate tolerance tests. You could either do the D-xylose test for malabsorption and the lactose tolerance test for maldigestion. And this ends our lecture on the fecal analysis, chapter 16 of your urinalysis and body fluids book. As always, please let me know if you have any questions. Thank you.